on this ongoing, keep it somewhat controlled. So I think that's where we're going to go, and especially because we're not catching these early enough. You know, we're still having individuals come in after it's grown quite a bit and really pushing it to, yep, we have to embolize, we have to do surgery. But then their long-term effects with the medications, I think, can be much better, because you know, after doing vascular anomalies clinic, they come back to us. and so that's what we're hoping for, is that we can get better control just of the disease process ongoing.
Well, I guess when I mean combo therapy, I mean like different simultaneous medications that you can give at the same time.
Oh, that's a great
rather
question.
than combined modalities. The medications is what I meant.
Right. You know, I think at this point we have not. And as I did the review and really spent time looking through the literature, I think one area that we can look into is if propranolol continues to be promising for lymphatic malformations, doing that along with sirolimus might allow us to use less sirolimus, so that would be helpful.
Okay, so with that, let's move on to the next session.
This is Frank again. I wonder if all the next presenters as a group can all sit down and sit in the panel section there in the front row. That'd be great.
As they're coming to sit down, I want to, my name is Henry Vasquez. I'm not on your program, probably for good reason, but I am happy and honored to be here. And I want to thank Frank Pepe for not only putting on this pediatric symposium, but also for all the work that he has done in recent and in past times. I also want to thank Bahar personally for her work in organizing, and I guess Antonio, who I haven't met yet, but I think credit goes to him as well. We're going to talk about a subject which is not that common, but as plastic surgeons, as pediatric plastic surgeons, we do come in contact with some of the aspects of neural tube defects, and I also want to mention that I'm very honored and pleased to have Dr. Jesse Goldstein from Pittsburgh also co-moderate this panel, and we will have discussion hopefully we will have discussion at the end of these presentations. This is just as a simple introduction, a heat map that indicates this is not a terrible, open neural tube defects, not a terrible or high mortality, but it is, as you can see, very disparate throughout the world, especially in areas of Africa, India, Pakistan, and some areas in Latin America. And you can see a little area also in Wales and in Scotland, which is of interest. And this is a graph indicating the prevalence or the incidence of neural tube defects before and after the mandate to enrich bread and cereal with folic acid. You can see that there is a dramatic decrease in the incidence and prevalence of this in the United States. Obviously, in other areas of the world, such as those that you saw on the previous map, they do not have this, and it is a cause of high incidence and eventually mortality in some of the more severe cases, such as anencephaly. I want to now refresh our embryology with how a neural tube or how the neurulation does take place. And you can see the neural plate is formed at around 3 weeks of age, so even before any of the cleft disorders start to occur, there is migration of this process from cranial to caudal. The cranial end, of course, is going to develop into the brain, the more caudal end into the spinal column. And then this neural plate then begins to form folds a neural groove at the center, and this is all happening within the first 3 to 4 weeks of embryologic life, and then the folds will form a tube that goes along the length of the embryo. And then at the top of the neural tube are the neural crest cells that then go on to form the peripheral nervous system. And so any defects along the way is what's going to form the defects that we will be discussing in this panel. This is a demonstration again of the most common problem with neural tube defects, which is spina bifida, which we do come in contact with as pediatric plastic surgeons when the pediatric neurosurgeon calls us because of a defect such as this, a monomeningocele, and after their repair of the meninges or the dura, then we are called to close this defect depending on the location and the size. So because obviously the best way to treat these defects would be prevention, we're going to get our first talk on something which is very close to prevention, and that is fetal surgery. Dr. Darrell, who is a pediatric and general surgeon here at the Cleveland Clinic, is going to talk to us about his experiences in that regard. Thank you.
Good morning. Well, we have some time pressure, I guess. I was asked to actually give an overview of the field of fetal surgery, and I'll try to just put the context of fetal surgery for spina bifida that might be helpful for you guys. And I'm honored to be here at this symposium where one of my former mentors, Bill Hoffman, is here as one of the faculty. I was an intern and resident at UCSF and spent 3 months as an intern on the plastic surgery service. So obviously fetal surgery is simply applying any kind of treatment to the unmoored baby, and that can be either in the middle of the pregnancy or right at the end. And so a classic example would be, a classic example would be a sacrococcygeal teratoma, which is a dramatic, life-threatening problem. You have to go in to save the life of the fetus. But we also can do things right at the end of the pregnancy to try to stabilize that baby's transition from the in utero environment to the postnatal life. There are a lot of different interventions, and there's been a lot of advance in this field in the last 15 years. We can do percutaneous ultrasound-guided things. We can do fetoscopic things. There's been some delay in the advancement of this field in the United States, and it's based on instrumentation. A lot of instruments and things have been developed in European centers, and there's been a delay in getting them approved and usable in the United States. And a lot of what we do today actually still falls under FDA regulation and approval. Open fetal surgery is the most dramatic, and then exit procedures refers to things we do at the time of delivery of the baby. And why the heck would we do this? We do this simply to try to improve the outcome. The most dramatic original examples were to prevent the fetus from dying, which is nice and black and white. If you don't do something, the fetus dies, and you have an opportunity to try to do something. You select fetuses that do not have lots of disability, so it's a correctable problem. These are not fetuses with lots of different chromosomal abnormalities, where theoretically, if we are successful, then we can restore a completely normal life. And it's more complicated to start doing interventions to try to improve the long-term outcome. And that's where we have to get into prospective randomized trials. And spina bifida is a classic example for that. To be able to do long-term outcome studies, we must be able to predict what the outcome is going to be. And a lot of the field has been developed based on trying to develop predictors of outcome for fetuses with different kinds of anomalies. There are a couple of pediatric and plastic surgeons, Michael Longacre, Pete Lorenz, who have significantly advanced the science of our understanding of fetal wound healing. It is clear that the fetus has unique healing capabilities that they're able to heal wounds better than postnatal animals and humans. This is a sheep-lamb experiment. This cleft deformity was repaired, by the way, but this is what it looks like 2 weeks later. But we won't go into that. This is a takeaway slide of the candidates for fetal surgery. So a fetus that has a lung malformation, these are almost always benign malformations. The lesion rarely grows very, very large. It can push on the heart. It can impair cardiac venous filling. And when the fetus develops fetal hydrops and signs of heart failure, if you don't treat, the fetus dies, and if you do treat, you can actually save the life of that baby, but it's fairly sophisticated surgery that requires a well-functioning interdisciplinary team. Also, a fetus that has a teratoma. These are vascular lesions. Sometimes the fetuses develop high-output physiology, and that fetus will die about 50% of the time unless you go in and do something. There might be a benefit to doing percutaneous treatments if you can interrupt the vascular flow successfully, but that hasn't been successful so far. Fetuses with airway obstruction, you all know about exit procedures for that, but you also can do exit procedures when you can predict there's going to be immediate cardiorespiratory collapse for other problems like diaphragmatic hernia, big lung malformations, some cardiac lesions, where you know you can do certain things while the fetus is still attached to the placenta. So you're taking advantage of the maternal fetal perfusion and oxygenation. You're doing it on placental bypass to stabilize that baby. These last two things, there's level 1 evidence supporting fetal intervention, twin-twin transfusion syndrome, which is done fetoscopically, and you know about myelomeningocele. There's probably a benefit to doing things to treat diaphragmatic hernia, bladder outlet obstructions, and for some cardiac lesions. And the really interesting thing about this field, like perhaps other things, transplantation, parents to child organ transplantation, is we have 2 patients, we have a healthy mom carrying a fetus with an anomaly, and we really have to balance the risks very carefully. Fortunately, there are generally minimal risks to the mother, except for undergoing a major operation. I'll just show you a quick case example of a fetus with a big lung malformation. The fetus has ascites, the lesion is pushing on the suprahepatic vena cava, the fetus went into heart failure and therefore required fetal surgical resection. If we hadn't done that, that fetus would have died with nearly 100% predictability. We do a fetal thoracotomy, we deliver this mass, the fetus gets bradycardic, it requires cardiac compressions, requires intracardiac atropine, epinephrine to resuscitate that baby. They're in tamponade physiology. We have to work with our cardiologist. The mass is removed, but amazingly, this all works. This baby was born about 10 weeks later, was intubated, extubated the second day. He does have a big scar. That's because I had to use the Bovie to do that. We were trying to operate quickly. The fetal operation took 18 minutes, and I used the cautery to make this incision, so it doesn't look too bad given that. And that baby went home. There he is at 1 year of age. There he is at 3 years of age. I want to show one other interesting case of a fetus with a gigantic lung malformation, really for one reason, is that that baby had virtually no normal lung, and that malformation was taking up the entire chest. It was removed, and here's post-op day 21, and the remaining lobe of the lung. This fetal MRI, if you looked at that, you probably can tell those lungs look pretty darn good. And then that baby was born near term and recovered very smoothly and is completely normal. And this is a patient that had an open fetal lung resection at 22 weeks, and he's an actor on the Disney Channel, now 14 years of age, good-looking kid. So fetal surgery can be done with good long-term neurodevelopmental outcome. Successful fetal surgery for these lung lesions has only been done in a few places. Some places have tried and has not been successful. It's important to have a good, well-functioning interdisciplinary team. And here's a teratoma. This presents some plastic surgical issues. This baby was in heart failure. Teratoma was debulked. And then this huge uterine incision was closed. Amazingly, it worked. She was born 10 weeks later. And she did require some revision of her surgery at her bottom, but is now 7 years old and doing great. I'm not going to here's an example of a gigantic lymphatic malformation that was deviating the trachea 4 centimeters, underwent an exit, went on to have resection. Actually, this patient did not have any sclerotherapy and had a good result. And then you can do exit procedures for these lung lesions as well. For very rare ones where there's very large lesions persisting at the time of delivery. So there's been sort of a general paradigm shift as we've gotten better with open fetal surgery and gained experience. And then as we've gained experience doing fetal interventions with fetoscopy for twin-twin transfusion, we've had a paradigm shift. And myelomeningocele is the example of that. So you know that this is an area of study that began in the Mike Harrison laboratory in the 1990s. And this set of experiments was done by a pediatric plastic surgeon, Claudia Muley, and her husband, who's a pediatric surgeon working in Zurich, Switzerland. And they did these lamb studies, and they proved the potential benefit of fetal therapy. And then 350 human cases happened, and then a prospective randomized trial took place. And fortunately, that trial proved the benefits of fetal surgery. And one of the really cool and dramatic things is these children with spina bifida have this Chiari-2 malformation with hindbrain herniation because of the open neural tube defect. And after you fix the defect, amazingly, that brain gets better. So here's the hindbrain herniation, and this is 1 month after open fetal surgery repair, and you can see the cerebellum looks dramatically better. And there was a randomized trial that many of you know about that proved there would be a benefit in these cohort that underwent fetal surgery. It cut the shunt rate in half, and it doubled their motor performance at 3 years of age with the ability to walk independently. Here's a few pictures of fetal surgery. And the really cool advance in this field is going to come in the future is doing this minimally invasively. These fetuses are not sick. They're not in heart failure. They're very stable. And this operation does lend itself to minimally invasive approaches. While I was in Houston, we were pushing that forward fairly aggressively, and about 50 fetuses have undergone fetoscopic repair. The operation at this point does not seem to be quite as good as open surgery, but it does give a fair amount of benefit to the uterus. Those babies that had fetoscopic repair could then deliver vaginally, and those moms could have completely uncomplicated future pregnancies with zero concern of uterine rupture, which does exist if you've done an open fetal resection. So I do think there's going to be a lot of advance in this field in the future. So that was a very quick overview, but to summarize, indications for open fetal surgery include a lung mass with hydrops and heart failure, a teratoma with hydrops and myelomeningocele. There's a bunch of indications for exits. And in the future, we're doing a bunch of things looking at fetuses with diaphragmatic hernia and developing less invasive techniques. Thank you very much for your attention.
That was a whirlwind, but nice job of making up some of our time. Thanks, Dr. Cass. I want to now introduce our next speaker, who is another one of the clinic's own in pediatric neurosurgery, Dr. Amuzulike. So why don't you come up here, and he's going to be talking to us about the neurosurgical component and management of these open neural tube defects.
So I want to first start off by thanking the ASMS for having me here. It's wonderful. I think our first time having it here, I believe, and a wonderful opportunity for me to discuss some of the things that we jointly do together. So thank you for that. I think these talks were well aligned. I'm going to really just catapult right off of Henry's discussion of embryology and David's discussion of some of the in utero myelomeningocele repairs that we do. Let's see. Awesome. I don't have at this juncture any disclosures, and I'm sure in the course of my career some will be coming, but at this point I have nothing to disclose. We had a quick introduction to spinal dysgraphism. Myelomeningocele, in particular spinal dysgraphism, is one of the more complex central nervous system congenital malformations that afflicts children and is still viable. The incidence is here 1 to 10 in about 10,000, and you can have both, as we saw with the embryology slide, anencephaly, which we know is incompatible with life, and then spina bifida, of which 90% of those are the myelomeningocele, which I'll discuss further. I'll kind of just skip over this. I think Henry did a great job describing it, but suffice it to say, from the development, which happens during the first trimester, you can have errors anywhere along the course of neural tube closure with the resultant myelomeningocele or meningocele, spinal dysgraphism, or anencephaly. These come in three major forms: oculata, meningocele, which doesn't have the neural tissue in the expanded portion of the tissue, and then myelomeningocele, which does carry some of those neural elements. Each of them has their own spectrum of different morbidities and subsequent harm to the child. Like Darrell kind of pointed out, a lot of different comorbidities are associated with these, including Chiari-2 malformations, scoliosis, tethered cord, and cognitive dysfunction. So even from birth all the way throughout the tenure of a child, you can have a number of these malformations associated with secondary morbidities. This is just, many of us have seen this picture, so I won't spend too much time, but you can see here the neural plateau, which consists mainly of neural tissue, which around that you then have the transitional zone, and it's an embryologic layer consisting of multiple layers of transition as you get out towards the dysplastic epithelium, which is disorganized epithelial tissue, and this is typically how it presents in the lower portion of the spine. It can occur anywhere along the spine, with the most common areas being the lumbosacral area. Initial assessment is usually made during the second trimester when the ultrasound is obtained, and you can